of the best years I've ever seen, actually, at any meeting for GU clinical cancer research. And that spans not only prostate cancer, but bladder cancer and kidney cancer. So I was blown away with the quality of potential standard of care changing data that was presented at ESMO 2023 in Madrid. I do believe that EV-302 establishes a new standard of care for first-line metastatic bladder cancer patients, whether you're cisplatin eligible or ineligible. If you look at the survival benefit, the hazard ratio was amazing for a very difficult to treat disease like metastatic bladder cancer. You can see that the median survival benefit essentially doubled. For those who received gemcitabine with platinum chemotherapy, it was about a median of around 16 months, which is about right what we expect to see. And that's now around 31, 32 months now with enfortumab vedotin and pembrolizumab. I think the other interesting thing is that the complete response rate is approximating close to 30%. I believe it was 29.1%. This is anecdotal, but I have a lot of patients that I've given enfortumab to and enfortumab pembrolizumab that have had complete responses. And some of them, when you stop therapy, they don't relapse. So that's really provocative when you think about what that implication could be having. Could we be curing more people even with potentially incurable cancer? Now, that's not everyone. That's a small subset, but across the board for all comers on those studies, on that study, that is EV-302, I think this establishes a new standard of care. I'm going to add the caveat that I don't think it means that you can't give gemcitabine platinum anymore. You can, and there was data with gemcitabine platinum or cisplatin and nivolumab. And we have to recognize the fact that enfortumab vedotin is not available at every single location in this world. And there are places where platinum chemotherapy is cheap and efficacious. So I will say this, I still believe that enfortumab vedotin with pembrolizumab is the best agent combination to give in that situation, but it's not the only standard of care. It is a new standard of care. There are always considerations. That's why it's ideal to have multiple potential standards of care, because there's no regimen that's going to be best for everyone. There's going to be situations where you just can't give certain agents. There are patients with, let's say, autoimmune disorders that you just can't give immuno-oncology agents to. Now, of course, that might exclude you from pembrolizumab in the EV-pembro combination, but that would exclude you from nivolumab in the gem-cis nivolumab combination from the CheckMate studies. But you can still give platinum. And so, again, I think for the vast majority of patients, do I have a preference to give EV-pembro? Yes. But there are patients that just can't receive immunologic oncologic agents. And for those patients, it's nice to still have platinum there as an option and other agents as potential options in later line therapy. So that's why we're not replaced yet with AI and with computers, is that we have to go through that risk-benefit ratio and carefully personalize our patient care, inform shared patient decision-making between the provider and the patient. Someday they'll replace me with AI, but not quite yet.